Professor El-Kalaoui, thank you very much for your coming and visiting us. And you have the floor to hear your speech.
Thank you very much for inviting me to be here. It's a great pleasure to be in Athens, and it's a great pleasure to be with old friends and new friends. It's a real pleasure to be here, and thank you for your very kind words and warm welcome. So today we're going to start about trying to understand what's happening, what's obesity, before we get into the topic of whether medicine is good, surgery is good, whether are we doing okay or not. So I'm going to give this talk, which I have given so many times before, and I hope that you would like it, and please feel free to ask any questions once we finish. So if we talk about obesity, obesity is not just weight, because we might find this kind of really muscular men, very athletic men, who has got a BMI of 26, 27, maybe 30, but it's all muscles. That's not obesity. Obesity is an abnormal fat distribution, so it's a weight, but it has got to be due to fat. Now, the results now and the data are trying to show us and has been showing us that actually 1 in 4 people has got a problem with obesity. And that ranges from being overweight all the way to be super morbidly obese. And it's affecting men and women, and it's also affecting adolescents, and it's affecting kids or children as well. And it's becoming like a health crisis. The WHO has done a mapping about the obesity problem in the world, and they've got a map like the one that you see on the screen to give an idea about where are the highest prevalences of different BMIs. This one is for morbidly obese. As you can see, it's in the United States, it's in Canada, it's in Egypt, where I originally come from, it's in the Gulf, and also it's in Europe and in Greece. So it's a huge problem. If we go to the normal weight, if we take the population and think about their weight, the ideal or the standard weight is around the BMI of 22 to 23. But unfortunately, this is the past. Currently, the BMI has shifted a bit more. So the average BMI is above 23. And what's going to happen is that in the future, probably the BMI, the average BMI will be 25. And as you can see that there is a shift of the average weight of a human being from being of a BMI of 22, and now we're hitting around 25. So I will not be surprised that maybe in the next 5 or 10 years, then there will be a change of the definition of what's normal. Because what's normal in terms of BMI and weight is under BMI of under 25. I will not be surprised that in 10 years they're going to say it's probably the normal will be under 27. And it's crazy, and it's progressing. So obesity is not just the extra few kilograms. It's not just being overweight. Because as obesity progresses and as time passes, we start to develop comorbidities that are related to obesity. One of them is diabetes. And with obesity, diabetes is only a time factor. So if someone becomes obese or morbidly obese, it's just a matter of time, and they will start to develop signs of diabetes. And it's not only diabetes. So we'll get diabetes, we'll get chest problems like COPD, we'll get joint problems, we'll get kidney problems, we'll get infertility in women, we'll get digestive problems like gallbladder or GERD symptoms or reflux problems, we'll get heart disease, and you name it. And not only this, because in obesity or a morbidly obese patient, these people or these kind of patients has got a difficulty to live a normal life. They can't get on a bus, they can't get on a train, and they sometimes find it very difficult even to go and have a shower if obesity goes into the extreme side or the super morbid obesity. Plus the psychological factor that is sitting in the background. So we'll end up having someone who has got severe psychological problems. Negative self-imaging, social isolation, and discrimination sometimes. What's the cost of obesity? The latest estimate, 2015 in the UK, is that we spend about £6.3 billion every year just because of obesity problems. It's huge. They think that currently we have crossed £10 billion. Obesity in the past, and I'm talking about 25, 30 years, we used to think that obesity is a lifestyle choice. It's just, this is the patient who doesn't live a normal life, who's not exercising enough, he eats rubbish, and it's willpower, and it's all psychology. While in fact, after a lot of research, we have found out actually obesity is a disease. So yes, there are factors in the environment, but more importantly, there are factors that are in the genes with some epigenetics, and it is currently recognized as a disease. So we need to stop blaming patients for being morbidly obese. We have to. I'm going to talk about the energy and the weight and the balance now. So basically, the basic equation for any human being is how much do I eat and how much do I spend in terms of energy. And the balance between those two things is going to affect my weight. Because basically, if I eat too much, spend too little, then I'll have lots of calories. If they get stored in my body, they will be transformed into fat, and that's obesity, that's weight. But we've got an important factor here, is the physiology, and it is the brain. And it's our brain who will calculate the balance between how much do I eat and how much do I spend. So the regulation and the brain will get signals from different parts of our body about how much food I did consume and how much food is being shred out of our body. And that's how the brain is like the computer. It's a central processor of how it will decide how the weight is going to be. And I'll come into this because this is really important in understanding how surgery and even how medications will work in the body regulation. The brain will get different signals from all these organs that you can see on the screen, right? But part of this comes from the gastrointestinal tract. So there are some signals that will come from the gastrointestinal tract that will go to the brain, and this is how the brain will partly interpret what's the weight, how much calories I have got, what do I need to eat, when do I need to stop to eat. And this is through what we call the gut hormones. Gut hormones is how surgery and medicine now work for weight loss. Now, the gut hormones are hundreds, but there are three very important ones that I'm going to just highlight. One of them is the hunger hormone. This is the devil. This is the hormone that gets secreted from the top of our stomach, from the fundus of our stomach. And this is the hormone that is responsible for hunger, and this is the hormone that is responsible for driving us to go and eat. This hormone was found that if I inject this hormone to normal animal labs, they put on weight because they make them hungry and they drive them to eat more. And also, if I repeatedly inject this hormone into animal labs, they move on from being normal weight to overweight. And these hormones in a normal human being have got three peaks. So I'll have a high peak of ghrelin in the morning, another high peak in lunch, and another high peak at dinner time. And this is the drive for us to eat. Now, not everyone will have three peaks. I am, for example, I'm someone, I never have breakfast. So I've tested my ghrelin hormones, and I found that I've got only 2 peaks of my ghrelin level. One is around lunchtime, when it's time for me to have something light, but then the peak ghrelin levels that I have, for example, is at dinner time, when I'm actually starving, and this is when I have a big meal. But for normal people, they will have 3 peaks. We wake up in the morning, very high ghrelin level, we have breakfast, and it goes down. Comes lunchtime, goes up again, I'm ready for lunch. Goes down, and then by dinner time, it goes up again, and I will have my dinner. Now, interestingly, when we do dieting, particularly obese patients, then the ghrelin level goes up. So we go and try to do some diet, right? First day will pass, second day, first week, second week. After the second week, they have found that all the peaks of ghrelin will go very high. And this is why, for any one of us who would like to lose 5 or 6 or even 10 kilograms, when we go on a diet, will be successful during the first probably week. But after the first week, it becomes very, very difficult because we're hungry all the time. And that's simply because our ghrelin levels are high. So we might have a small meal, but we're still very hungry. And this is exactly what happens in obese patients. And that's why when you ask an obese patient and say, go and have a diet, fine. They will go and try the diet. And then they will go for the first week, and they're fine, but then they start to struggle. So after 3 or 4 weeks, they fail because they're hungry all the time. And this is when the weight comes back again. And that's the story of any obese patients. I lose weight, but then I put it back very quickly because I cannot carry on with the diet. The second hormone is not the devil, actually it's the angel. This is a hormone that gets secreted from our gastrointestinal tract when we eat. And this is the satiety hormone, and it's called peptide YY. So after eating, once the food reaches the stomach, or to be more specific, the first few centimeters of the small bowel, including the duodenum, that hormones go high up in our blood levels, goes to the brain, hypothalamus, and signals, I've had food. And this is the hormone that stops us from eating. So when we eat, we're hungry, we eat, stomach starts to become full, and then after a stage, I'm too full, I can't eat. Part of it comes from the stretch receptors of the stomach, but another part comes from the peptide YY, which goes to the brain and signal, I'm full, I'm not going to have any more. And that's why in normal people, once you finished your food, you're not interested in anything else. Even if you see something that is looks very nice, no, I can't have it. That's your brain. Peptide YY release in our blood depends on the amount of calories and the richness of food that we eat. So if I go and eat a small sandwich, yes, I'll get a bit of peptide YY, but it's not the same if I have a full meal. If I have a 2,000 calorie meal or a 1,500 calorie meal, the peptide YY levels are going to be extremely high. And that's why I will never eat anything else after that. So sometimes I might skip dessert. But if I eat a small sandwich, no, I can eat something more. And it's simply because the levels that get secreted from the bowel are directly related to the amount of calories that we had. Now, interestingly, this happens in adults and children. So the levels of peptide YY depends on how much we eat. And interestingly, in anorexia patients, for example, they've got a very, very high levels of peptide YY. And that's why if you see an anorexia patient, you will find that I don't want to eat all the time because their peptide YY levels are so high and it's stopping them from eating. The last hormone that I'm going to talk about quickly is the GLP-1 or glucagon-like peptide. And this is the basis of all the medications that we've got effectively running now to treat obesity. So what does GLP-1? GLP-1 makes people lose weight by different mechanisms. So the brain, the gut, But more importantly, GLP-1 will stimulate the body to produce insulin in response to carbohydrate intake. And that's why these enzymes are not only very, very effective in weight loss, but they are very, very effective in diabetes control as well. And all of these hormones get secreted from the gastrointestinal tract. And all of these hormones will change after bariatric surgery in favor of weight loss. So what happens of all of these gut hormones in obese patients? You bring any obese patient, morbidly obese patient, right? Any BMI above 30, for example, okay? You will find that the hunger remains still after having a meal. It's simply because their ghrelin levels are high all the time. They're hungry all the time. And when they eat, they don't feel as full as any other normal human being, simply because their peptide YY levels does not reach that high levels, right? So that's why they eat, but then they're still very hungry, and they eat again. And when they eat, they're never full. And that's the problem about obesity. And that's why we stopped blaming obese patients for their fault. So I cannot go and say, it's your fault. You're the one who's not eating healthy food. No, there are hormones that are playing from the gut to their brain to drive them crazy. That's the drive for them to eat all the time. So we have to stop blaming them. It's not their fault. It's the bad biology or the disease that they've got. Just a simple equation, just a simple idea for you. Again, we talked about how much we eat and how much we spend. Fine, fair enough. And it's the balance. If I've got the right balance, I'm fine. Let's say that I've got a BMI of probably 21, 22. So probably as an active male, running, traveling, talking, giving a talk, going to Greece, back to London, I would probably need about 1,700 calories a day, right? Maybe 1,900 calories a day. If I get those every day, and I'm doing what I am doing, I'll maintain my weight. But actually, I eat more than that. So why is it that I'm not big? Why is it that I don't put on weight? And why another colleague of mine would probably eat the same, but then he's putting on weight all the time? It's simply because of one factor that I'm going to explain in a minute. They have counted any one of us probably will need just under 1 million calories per year to maintain the weight. That's the average intake for a human being per year, 1 million calories, right? And they also found out that for any person who has crossed the age of probably 45, maybe 50, there is a trend to put on some weight. As we get older, we'll put on some weight. And on average, a human being will put about 1 pound or just under half a kilo per year. If you do the math, to put on half a pound per year, all what I need for the whole year is 4,050 calories. This is to put, right, half a kilo for a whole year. If we divide that by the 365 days of year, then I need to have only an extra 1,100 calories per day to put half a kilo at the end of the year. Only 100 calories. That's 1 chip. So all what I need to put on half a kilo at the end of the year is to have 1 extra chip per day. So that doesn't make any sense. So there must be another factor in the background that is stopping us from putting on weight, because basically any one of us is definitely having more than 100 calories per day. And it is the brain. And it is the brain that has decided, for me, this is my norm. This is my weight. This is my comfort zone. I need to be around in the region of 21, 22 body mass index region. If I eat more, the body will get rid of the calories. If I eat less, I'll feel more hungry to eat more. And that is exactly what's happening in a morbidly obese patient. The brain wrongly understood that my norm is to have a body mass index of 50, for example. So if you eat less, then the body is going to drive the body to eat more so that they can get enough calories to maintain the body mass index of 50. So again, it is the brain, right? And as we started to say that actually diabetes is not a problem of the pancreas, we're starting to say it's the same, that obesity is not a problem of just only fat. It's a problem in the brain. And I'm going to explain in a second why the brain. So after all of this, and after all the numbers of obesity in the world, are we doing enough? If this is the problem of obesity, BMI above 25, this is obesity, which is BMI above 30, morbidly obese, which is BMI above 40, this is what we're doing in terms of surgery. So we're not treating enough patients. Even if we add a bit of medical treatment as well, we're still not doing enough. So there are millions and millions and millions of morbidly obese patients in the world who don't get treatment. What do we do in surgery? We do a lot. We used to do the gastric band, which we don't do anymore. There are some centers who still do it, but actually it's not effective for so many reasons. We do the gastric sleeve, which is currently the most commonly performed operation worldwide, and Nicholas is going to talk about it. We used to do gastric bypasses. I used to do much more gastric bypasses than I do now, but I've shifted the practice for reasons that we're going to discuss at the end after Nicholas' talk. And we do the extreme operations like the denal switch, SADIs, or mini gastric bypasses. They all are effective. Now, in terms of effectiveness, if I ask the patient to just go on a diet and exercise, that's the weakest in terms of weight control. If I do an operation, that's the strongest in terms of weight loss. But currently, we believe that it should be a combination of all of that, including medications. So why do we do it? We do it because it's extremely effective. It has been proven that bariatric surgery is the most effective way of weight loss. Currently, we're having a debate whether medicine is as good as surgery or not. The latest kind of publication are suggesting that medications are very, very effective, and I'm a big advocate of them because most of the medications came from the University of London. But in certain cases, and not in every patient, and surgery still has got the upper hand in terms of weight loss. But medications work. They 100% work. They are effective, they are good, but they are not for every patient to be used. Gastric bypass used to be the gold standard, not anymore. Gastric sleeve is probably the gold standard now. And it's the most commonly performed operation, and I'm not going to talk about it because that's Nikos to talk about it. Gastric band, as I said, we stopped doing them. And we've got other options like the balloon, the gastric plication, None of them in the era of surgery and medications, they're not. I don't find them effective at all. It's just a waste of money and a waste of patients' time. This is another extreme, which is something called endobarrier. It's an endoscopic procedure that we used to do, not as effective. The Swedish study in 2007, and then after that with the latest publication in 2013 and 2016, have clearly demonstrated that the most effective way of weight management is surgery. And the effect is that after weight loss, we'll get rid of diabetes, we'll get rid of sleep apnea, we'll improve the cardiometabolic problems of the whole body, and all the others, including fertility, including joint pains, lots of things. How does it work? It works by so many mechanisms. One of them is stopping the patients from eating. And again, it's going to go back again to the brain, which is going to stop the patient from eating. So how would this happening? And as I was hinting earlier, is simply because of something called the reset or the reset body or the brain set body. Remember when I told you is that why is it that I'm eating too many calories and I don't put on weight? Because my body is happy with my current BMI. Why is the bariatric patient has got a very high BMI? Because his brain is happy with his weight. So the brain have decided wrongly that this is my right weight. This is how I should be. And the brain is going to fight to maintain this weight. What happens after bariatric surgery is that if the brain decided that my correct weight should be in the region with a BMI 40, after surgery, the brain will understand that my set point will need to be around 30. And that's why weight loss after bariatric surgery is not difficult as weight loss with diet, because the gut hormones are supporting. The gut hormones are not working against the brain, they're working with the brain now. Because after bariatric surgery, there will be no ghrelin, so there will be no hunger. After bariatric surgery, there will be a very high peptide YY. So even with a glass of water, the patients will get high PYY that's going to tell the brain, I'm fine, I don't want to eat anymore. And interestingly, I don't know if you've seen it or not, but then for us as bariatric surgery, we do an operation on a day. On the next day, you go and see the patient walking around happy, and they would say, it's very strange. At this time of the day, I'm usually starving and I'm looking for anything to eat. Now I don't feel that I'm hungry at all. This is the gut hormones. And this is the shifting of the brain set point from being, no, this is my comfort zone. Now the brain starts to say, no, actually, this is where I need to be. And that's how they lose weight. And don't forget that after bariatric surgery, if you remember the slide when I said that every human being, as we get older, tends to put on weight, then after bariatric surgery, that's the norm of a patient. So we do bariatric surgery and their weight drops back in. But the progress of the natural physiology of the body is to put on some weight as we get older. So any patients after bariatric surgery, once they reach the bottom, they will start putting some weight slowly. But then they will start putting some weight, not starting from body mass index of 50, but from a body mass index of 30. And this is what we need to factor in when we see patients 5 or 6 or 7 years after surgery saying, I've put on 3-4 kilograms. Yeah, that's normal. That's the natural physiology. That's the natural progress of a human being. That's not weight regain. So collectively, I would like to mention that bariatric surgery are fundamentally different from any other measure of helping the patients to lose weight. It works by completely different mechanisms. It's not like asking them to go to the gym or asking them to go on a diet. No, they don't work. In my 25 years of bariatric surgery kind of journey, I've seen only one patient who has managed to lose the weight with diet and exercise and hasn't put it back. He's a surgeon, he's a friend of mine, very close friend of mine. He's an ENT surgeon. I've scoped him because I thought that he's got very alarming symptoms from his stomach. It looked like some cancerous problem. Luckily, stomach was fine, just H. pylori. But then we discovered at that time that he's got diabetes, very high cholesterol. That was just before COVID. So the guy said, fine, I'm going to change my life. I'm going to change my appetite, my eating pattern, and I'm going to lose weight. And I told him, Sharif, that's not going to happen. Get ready. I will operate on you in the next 6 months. In 6 months' time, he has lost 50 kilograms. And he's never put it back. He's as slim as me now. That's the only person that I've seen in my journey who has lost weight with diet and willpower. And that's documented in the literature. They say that 1 in 6,000-7,000 people might just lose the weight and maintain it for 5 years. And that's the only one that I've seen. It's very, very hard. Now, what's happening now is that we're seeing lots of these injections. So we started with Trulicity, and then we've got this, and we've got Ozempic, Wegovy. Currently, we've got the Mounjaro, which is tirzepatide. We started with one hormonal agent, which is the GLP-1. Now they've added the GIP, which is dual action. Currently, very effective treatment. And the 3 agent injections are coming in April, May 2026. Extremely effective, but I'm going to leave it to my colleague who's going to talk about it. Thank you very much.
Thank you very much, Professor El-Kalawi, for your nice speech explaining us the pathophysiology of obesity. I would propose the questions should be set at the end of the session. And let's proceed with Mr.